Hello and welcome to the first POCUS Journal Podcast. The POCUS Journal is a resource for the latest information and case studies on point-of-care ultrasound written by physicians, ultrasound users, researchers, and educators. My name is Amer Johri, and it is my pleasure to present today's article entitled The Focused Assessment with Sonography in Cancer, or the FASC Protocol, by Dr. Peter C. Nauka and Dr. Benjamin Galen. This article appears in the November 2020 issue of the journal, Volume 5, Issue 2. It is my great pleasure to present Dr. Jamie Galen, or Dr. Benjamin Galen, to first tell us about this protocol. Jamie, can you please go ahead and tell us about your interesting article?
Dr. Johri, thank you so much for your time and for your interest in the FASC exam. And I want to thank Dr. Nauka, first of all. He's an outstanding resident in internal medicine here at Montefiore Medical Center and Albert Einstein College of Medicine. And he's been a collaborator of mine on some projects. And this article really owes a great debt to him for his work in putting it together with me. The FASC exam was an idea that I had a few years back, and it borrows from a widespread application of point-of-care ultrasound in emergency medicine and trauma and surgery, which is a very well-known FAST exam, the focused assessment with sonography and trauma. And the FAST exam is probably one of the more popular protocols in point-of-care ultrasound that's in widespread use, and it really uses it takes advantage of the sensitivity that ultrasound has for finding fluid, and that's so critical in trauma because of the presence of intra-abdominal fluid in a trauma setting prompts further investigation, CAT scan or XLAP, because it's thought to be a great screening tool to detect intra-abdominal bleeding. And the FAST exam is is in such common use that it occurred to me that that this really has a potential for being adapted to medical applications, and the need for finding fluid in medical patients really is already in common widespread use in emergency medicine and critical care and internal medicine, hospital medicine, and the fluid sites are really the same as for the FAST exam. So this protocol borrows from that already well-established application. And I think the other area of need is that oncologists and hematologists it's a field of internal medicine that doesn't currently use point-of-care ultrasound, in the way that some other subspecialties of internal medicine are doing, and so the need exists from our perspective to provide a framework for training many different types of users in this exam for patients with cancer. And
that's great.
Mhm.
So how does this protocol specifically differ from the FAST protocol?
It actually doesn't really differ too much in the sites that we're going to suggest scanning. So those are standard POCUS windows. The right lung base and upper abdomen, the subxiphoid cardiac view, the left upper quadrant, the lower abdominal quadrants, and the suprapubic pelvic view. Those are kind of standard FAST exam sites. It's just really applying those to patients with cancer.
That's right. So instead of, for example, the application in trauma, here you're promoting its use in the medical wards and in patients that are presenting to the oncologist.
Exactly. Yeah, and I think that's our impression that many effusions, pericardial effusion, pleural effusion, and ascites, they are paraneoplastic or malignant findings that are so important for management, often present late. So they become symptomatic when they're in extremis, and we see them in the emergency room and in the hospital. But obviously those fluid accumulations were not developed overnight, and so sometimes they can be rapidly accumulating, but typically detecting them early might allow for some interventions that that could be pursued prior to when they became symptomatic, but they're also of diagnostic importance. And ultrasound is so sensitive for fluid. We mentioned in the article the general sort of cumulative sensitivity and specificity for these different sites to find fluid, and that's based on gold standard CT scans or other reference ranges for ultrasound to find fluid. But our hope would be that oncologists and other doctors would find the FASC exam applicable to outpatients as well.
Great. And so could you give us an example, even a hypothetical example, in which an oncologist may incorporate the FASC exam into their clinic practice if they're seeing someone one day in their clinic? How could this play out? Is there a scenario you could suggest?
Oh, I'm so glad you asked that. I think even stepping back one step further, I think that an oncologist or an oncologist in training might be interested in learning the FASC exam, whereas they may not necessarily have the time or resources to learn how to do cardiac POCUS or limited echo, those kinds of more advanced training skills. But this may be something that they can learn as a protocol because it's so straightforward and can be done with a handheld ultrasound, portable ultrasound, and it's something they could learn as a resident or as a fellow, and then take into their practice. And so I think part of the intention of a simplified protocol like this is that it can be easily taught, and it can be it can be replicated and then evaluated further. But to get back to your question, a scenario would be a patient with known stable metastatic solid tumor, let's say colon cancer on advanced therapy, is coming to clinic pretty frequently for evaluation, and their other modalities of imaging may not be spaced out any more frequent than say every 6 months or a year perhaps, but they may come to clinic for other general complaints and symptoms. And I think the ease of being able to trend this exam is really one of the appeals for the outpatient doctor. If you were relying only on physical examination, to trend the ascites or trend the pleural effusion, that's quite limited in sensitivity. Other imaging is very inconvenient for patients with cancer who are already schlepping around. Certainly a time like this with the COVID pandemic, the last thing you'd want to do is have to make an immune suppressed cancer patient wait in a waiting room for an X-ray that they didn't necessarily need. So the idea would be that the cancer doctor could see the patient in clinic, find say a trace or small pleural effusion, and then have them come back for a routine or intentionally for another visit and say several weeks to a month to reevaluate that, and then be able to trend the size of that fluid collection. The same would be for ascites. Pericardial effusion is a more nuanced arena, I think, in terms of determining when to refer for formal echocardiography to evaluate for tamponade features. That's a more complicated, advanced area. Our suggestion is that new pericardial effusions in patients with cancer should be evaluated by formal echo, upon discovery. But the idea would be that they could then coordinate next steps with evaluating that fluid, either by referring for diagnostic sampling of the fluid for cytology, or that they might be able to do that themselves in the office as well, especially for abdominal fluid or fluid in the chest.
That's right. So you mentioned the word trending, and I really like that because it suggests careful and continuous follow-up. And so this modality, in fact, promotes that continuity of care. What are your thoughts on how an image is exactly put into a trend? I know different institutions have different approaches in terms of saving images, and so that they could compare them. What are your thoughts? What are some models that you have seen? I know it's a little bit of a controversial area, but I wanted to hear from you.
Yeah, no, it's such a great issue for continuity. I think for the a group practice, let's say that one member of the practice was on rounds with the handheld ultrasound, seeing their patient in the hospital. They had a CT scan or chest X-ray that had some impression of fluid at one of these sites, so-called positive FASC exam. The That provider could take images with a handheld ultrasound or a cart-based device, and there are different image archival options that are available, commercially available. Many hospitals use a PACS system, which certainly could be adapted, for these images, even if they're not read by, radiology. They can be stored for retrieval. There are some other products out there. I don't have any, endorsement or relationship with them. Some other companies that have image retrieval, in the cloud as well. I think there are popular handheld devices that have cloud-based image archival systems integrated into their products, and so that would be a chance for the a more precise trend, as opposed to using words in the paper chart to describe the fluid. If a provider stored a picture of the ascites on discharge, and the patient came to see their colleague in the cancer center after discharge, and they were preparing the visit, the other provider could look at the images on their practice's image archival system, whether it's PACS or QPath or the cloud-based archive, and look at those images and then compare it to the present findings. And so that might be a more more precise trend over time, trending the FASC exam, rather than just relying on someone else saying that it was trace or small or moderate or large.
That's really
Yeah.
interesting and an important point. So, in terms of the FAST protocol, some of our listeners may not be familiar with the FAST protocol. So, are you able to summarize the key views that you would like our readers to take away from this article that you present, which, by the way, also appears on the cover of the POCUS Journal in the latest issue?
Oh, yeah, thank you for asking about that. I do want to also add that the FAST exam and the FASC exam, using point of care ultrasound, there's no radiation in those exams. These are safe, ultrasound done at the bedside, which is so convenient for patients, and also safe. And so that's another appeal for that exam. The figure that we devised, and I really do want to thank Dr. Nauka for this terrific graphic. It's in figure 1. We identify 6 points, windows to include in the exam, and this is based off the abdominal windows for FAST exam. There are different protocols that add some additional nuance to some of the areas, but one of the popular sites, for instance, which is our point number 1, at the right lung base and the right upper abdomen, that's combining fluid that would be above the diaphragm, pleural effusion, and also looking for subdiaphragmatic ascites, as well as a sensitive place to look for fluid is in Morrison's pouch, and this is from the FAST exam, because it's a dependent area. The hepatorenal recess, or Morrison's pouch, is a place where a very small amount of fluid might accumulate. Now, in a patient with known, carcinomatosis, that may not be something that's able to be sampled, or it may not be symptomatic, but it may be clinically important to identify that it was happening in terms of the ongoing treatment plan for their cancer. So that site is number 1. That's at the right upper quadrant, abdominal and the right lung base. And because you're on the right mid-axillary line, it's easy to slide down to the right lower quadrant from there, really to look at fluid in the lower abdomen and pelvis. And from there, you can fan or tilt anterior posteriorly to see bowel and differentiate that from ascites. Fluid, as you know, is anechoic, or black on ultrasound imaging. There are no echoes, but there may be complexities to fluid. Patients with cancer have highly exudative fluids, and sometimes the the fluid can be complex and loculated with internal echoes and fibrin strands and those kinds of things. The site number 3 goes up to the subxiphoid cardiac view. This is typically a rescue view for a lot of cardiac POCUS, but it's really good for fluid because you see the posterior when the patient's lying semi-recumbent. You can see their fluid if it's dependent. It's oftentimes a window that's easy to get if some of the precordial cardiac windows aren't necessarily as easy to obtain. But this would be the step number 3 to look for fluid and pericardial fluid. I think it's important to note that these different fluid spaces can be challenging to differentiate. Especially for beginning users, sometimes pleural effusion, ascites, pericardial effusion can be present in the same exam and can be challenging to differentiate for a novice beginning user. But I think this is the more you do these kinds of scans, the more you compare them with other imaging modalities, the more you're able to interpret them accurately. So the next step is coming across to the left side, and that's the same as the position number 1, but now we're in position 4. This is the left lung base and the left upper abdomen. And that would be the splenorenal space where a small amount of fluid might be dependent. Because the left renal space there is more posterior often than the right, it can be even more sensitive for a small amount of fluid. And from there, sliding down to the left lower quadrant. And then the suprapubic pelvic view is looking at the bladder and the nearby fluid that might be in the pelvis. So those are kind of the 6 basic sites that we came up with. And I hope that answers your question.
That's excellent. Yes, and I'd like to remind our listeners that these 6 sites are highlighted on the cover of the journal and also appear as a figure in the issue. One of the other questions I have is that you're really pioneering a new application for ultrasound amongst our oncology colleagues and others in medicine that may be seeing patients in this population. My sense is that right now, because this is a new area, there aren't too many resources and training recommendations available. Is that something we need to work on for the near future?
Definitely. I think that that in the U.S. the path to oncology is through internal medicine, for medical oncology. But I think there are so many people, so many doctors that treat cancer in different fields. They come through different programs. It'd be nice to have a standardized protocol where if a medical oncologist could tell a radiation oncologist about the FASC exam that would have a similar terminology, they'd understand what they were referring to. That's kind of where the FAST exam is. It's understood by surgeons and emergency physicians and other doctors, and so it's interdisciplinary. And I think that right now, the training programs are so varied in terms of how much content they're offering for point of care ultrasound. But undergraduate medical education is another arena where this point of care ultrasound is so much on the rise, and so having additional succinct, kind of catchy FASC exam, it helps to kind of codify that protocol and make it something that the future oncologists who learn ultrasound in med school and in residency could take with them and then teach their colleagues. But also, you're absolutely right. There's no formal or informal point of care ultrasound training for medical oncologists that I'm aware of, but I think that it really might be something that could be offered the way that it is in other fields, as workshops to national conferences is a typical setting. So, 1-day workshop or even a half-day workshop, learning how to get these 6 views and learning how to interpret the findings accurately, and an introduction to point of care ultrasound. That would be a very feasible venue to teach that, for users that are interested. The conference setting is a terrific one, but I think also for trainees who learn a broad range of POCUS applications, they could then take this with them, into their practice.
I agree, and I'm really looking forward to hearing about what your group may do further to disseminate and standardize this approach, because I think it'll improve patient care. Specifically, can you tell me a little bit more about some of the next steps for your group or your areas of research and education?
Well, that's such a great question. I think that our next steps would be to try to get our oncology colleagues on board with the the protocol and understanding that this is not maybe part of their mandatory curriculum for board eligibility yet, but it's something that we would want to teach. And so I think the next steps would be to see if the oncology fellows would be interested in learning this protocol as part of a pilot program. I think that a pilot curriculum for the FASC exam would be a really good way to go, and then have some outcomes. I think both in the short and long term would be really helpful. So kind of validating the protocol for the cancer doctor, that would be the next step that I'm hoping to to get into, is seeing about developing a curriculum around the FASC exam and then evaluating it.
That's wonderful. So I would like to thank you, Dr. Galen, again for joining us. And once again, for our listeners, the article is entitled "The Focused Assessment with Sonography in Cancer, or the FASC Protocol," which appears in the November 2020 issue of the POCUS Journal. I would like to thank our listeners for joining us on the inaugural POCUS Journal podcast. We look forward to bringing you more content from the POCUS Journal in upcoming episodes. And Dr. Galen, I'd like to thank you for joining us for the special first podcast for the POCUS Journal.
Dr. Johri, the privilege was all mine. Thank you so much.
Thank you.
Have a great day.